Hi, I'm Dr. Jack West, medical oncologist from Swedish Cancer Institute in Seattle, Washington, and I'm also the founder and president of GRACE, Global Resource for Advancing Cancer Education. And I'm happy to be here for a post-ASCO 2017 update with two of my colleagues. With me is Dr. Matt Gubins, who is Associate Professor in Medical Oncology, Specialist in Thoracic Oncology at the University of California, San Francisco, and Dr. Jyoti Patel, who is Professor in Medical Oncology at the University of Chicago, in Chicago. Thanks for joining us.
Thank you.
Thanks for having us.
Another interesting, but I'd say surprising presentation at ASCO was one that directly compared two EGFR inhibitors in patients with advanced disease and EGFR mutations seen in about 10% or so of our patients, and more commonly never smokers, younger, but certainly not always. And this was a global study comparing a well-known and commonly used agent, Iressa, gefitinib, that's been around for more than a decade, the newer drug that isn't commercially available called Dacomitinib. And in general, there have been some other studies with this agent that frankly led to some skepticism that it would be a big payoff. Not only that, but there have been a few other studies of one agent versus another EGFR inhibitor that didn't show very significant differences if they were even detectable at all. But this study showed that Dacomitinib had a quite significant improvement in the time to progression and requiring another therapy. It was about 9 months median, the halfway point of where half the patients have progressed, half haven't. 9 months with Iressa, very typical, and closer to 15 months in the patients who got Dacomitinib. But that agent has had a lot of toxicity issues, and 2/3 of the patients needed a dose reduction, and it's also not on the market. So do you think it's going to have a place, or there's other agents kind of on the periphery? We might see Tagrisso, a second line agent, moved to first line. So where do you see the space going, Jyoti?
So there are currently 3 EGFR drugs that are approved for frontline therapy, so Gilteriv, Tarceva, and Iressa. And I think most of us sort of put them on a spectrum, and maybe Iressa is the one that probably has the least toxicity, then Tarceva, and you can play with the dose a little bit there, and then Gilteriv. And Daco's a lot closer to Gilteriv in terms of design and probably tolerability. We've learned significant lessons with Gilteriv in the past couple of years, in that we can manage side effects and handle toxicity if we have a patient that is motivated, and a nurse that's motivated to sort of manage the right dose. So my sense is that Daco just kind of adds to Gilteriv. I'm not sure if it really comes out ahead. But as you alluded to, what's really exciting is to see whether Tagrisso really is going to be a superior drug in terms of frontline therapy. So that's mutant selective. So we know that it hits EGFR that is activated, and you get less skin and GI toxicity. Moreover, it overcomes one of the most common resistance mechanisms. So currently we use it after resistance is developed. This would really be bringing it to the front line. All of us have different expectations of how good that drug has to be. We all like it because it's easier for most of our patients, and we know it has great activity in the brain. But I think we as a community are trying to figure out whether it needs to be sort of 1+1 to make it that much better, sequential therapy, or whether...
And how much tolerability matters.
Right.
One of the other key points that neither of us focused on was that this trial that we talked about excluded the patients with brain metastases, who are many of those who present with an EGFR mutation-positive lung cancer. So it's kind of cherry picking here, and so there's certainly going to be a lot of factors. Matt, what do you think, and you're weighing all the options available or potentially available to you as we get the results of the so-called FLORA trial of Tagrisso versus the first-line treatments?
I think the devil's really in the details, and I think you make an important point that definitely in the study, Daco did better than Iressa, but the patient population missed those brain metastases patients, and those are a really important subset of whom we're treating. And knowing that certainly the first and second generation drugs do a reasonable job in the brain and the central nervous system, but that the drug Tagrisso has much better effect, not only in the brain, but even in the spinal fluid around the brain. That as Daco, one of our colleagues made an interesting analogy, and I'm admitting to copying it. I feel like Daco was kind of a single or a double in baseball, whereas Tagrisso, we have to see if it's going to be a triple or a home run. If we can really see, as we saw in the ALK world, a doubling of the benefit of Tarceva, Iressa, Gilotryf, that really will really sway, I think, most of us in the field to move toward that in the first line. We talked about sequencing. In ALK, every patient until now used to get Xalkori and then Alecensa. In the EGFR world, if everyone gets to Tarceva, say, in the first line, only about half of them qualify for Tagrisso in the second line.
Right.
If they don't qualify with the so-called gatekeeper mutation, T790M, it's often time for chemotherapy. Bringing it forward where everyone can get it and get the brain benefit and get the toxicity benefit really, I think, is an important move. And again, we're all presupposing what this FLORA trial will show us, and again, devil in the details, we'll see what it shows. But Daco is an important proof of principle, and I think were it available, and again, it's not approved in the United States, so it's actually not an issue for us at this point. It would be a discussion with patients about whether, until we see how Tagrisso does in the first line, will a patient want to take some extra toxicity for a possibility of not a huge improvement, but some improvement, which I do believe
It's hard to say, because we're always wondering in these patients who fortunately can have several treatments sequenced over years, whether it's going to translate to more living longer by the end of all of that. And the very significant difference in side effect profile for this agent versus Tagrisso, which would largely be a more favorable trade. And to your point about Tagrisso or about Dacomitinib being having a double here, yeah, it's a solid extra base hit. It's just not clear if it's going to be stranded at second or eventually cross the plate with an agent that isn't approved and not being used right now.